Germany, in the trauma unit there. One of the more challenging things we have to face, anybody can nail, I think, anybody in the room here can nail it, mid-shaft tibia fracture, but Matthias is going to have a bunch of tips and
to every distal tibial fracture by intramedullary nailing. What I just want to point out are the critical points in nailing proximal and distal fractures, and to be aware of these problems to occur in your daily practice. At the end of this session, you should identify good indications for intramedullary nailing in closed and open fractures. You should be able to outline principles and problems in the management of proximal and distal fractures focused on intramedullary nailing. And you should be able to explain the anatomical basis and techniques for nail insertion, including the use of blocking screws. And you should be able to evaluate ways to avoid complications or to treat them. What are the advantages of nailing of the tibia in general? First of all, it works. It works in most fractures of the shaft. It's a soft tissue-friendly procedure. You need limited incisions in general, far away from the fracture, and you have a good option for wound care. You have low infection rates, and it works great in shaft, segmental, and comminuted fractures. But what are the challenges? The challenges are lying in the proximal and distal fractures. There it's very hard to control axis, rotation, and length because you have a very short proximal fracture segment and one long or one longer or two longer distal fracture segments that you have to fix onto this short fracture segment. Sometimes you even have articular involvement. If you nail proximal tibial fractures, you may run into problems with classic deformities. First of all, it's the valgus deformity, then the extension of the proximal segment, which gives a pro-curvatum deformity, and you may obtain an anterior translation of the proximal fragment related to the shaft. This even may happen in fractures that seem to be not so far proximally, as you see in this case. How do we get varus and valgus? If you go in with a nail in a slightly oblique direction and you pass the fracture in a slightly oblique direction, the nail in the further step of the operation will orient straight in the shaft and the proximal fragment will get a secondary malalignment. This is working for valgus and varus malalignment as well for the procurvatum deformity. You have an oblique passage of the nail through the fracture, and once the nail enters the shaft and gets an axial orientation, the proximal fragment will tilt. You see the clinical situation of malalignment, and in these cases, two similar fractures were treated with similar implants with different techniques. You see a high lateral starting point. This will be a topic of the later phase of the talk. And you see a rather medial starting point, and you get this valgus deformity in the right case, and you get an anticurvation, a procurvatum deformity with anterior translation. The problem is that one might think that the nail ends up with a good alignment once the passage from the proximal to the distal fragment is obtained, but the fracture is not automatically reduced if located very proximal or very distal. This might happen in isthmic fractures, in shaft fractures, but not in the proximal and distal ones. Therefore, I would like to change this picture. And you see many reductions, reduced, and things like this. So, first reduce your fracture. Then maintain the reduction. Keep the reduction with passing the nail over the fracture, and keep reduction during locking the nail. In between all these reduction procedures, you have to look for the optimal entry portal for the nail to get little stress on your reduction. Therefore, I would like to show you some things as reduction tools and technical tips. For reduction tools, we have seen many things in the last talk, so I just emphasized on the femoral destructor. Then we go to the nailing procedure and the optimal entry portal to minimize our stress during nailing. And then, once we are running into problems, we go for correction by blocking screws, or we may use this technique for primary good reduction. The femoral destructor. should in general be placed medially. And if ever you place a destructor, keep in mind your later insertion way of the nail. And if you place it in a medial position, be sure that the destructor will not interfere with your later interlocking options of the nail. If you choose the entry portal, it's a work, it's quite 12 years old. You can use a medial destructor for reduction, and then your entry portal must be lateral and very high. The bias of this is that if dissected from proximal to distal, the tibia is somewhat triangle shaped with the largest diameter on the lateral side. This is where you have to get your nail in. So we see a perfect example of a segmental fracture with a very, very short proximal fragment. And we see the use of almost every useful reduction tool. You see a medial destructor. You see percutaneous clamps just to close down this proximal fracture gap. You see temporary K-wires across the fracture gap. And distally, you see a temporary plate just holding the alignment. And then the operator went to a very high and very lateral insertion point, just in projection of the lateral tibial spine in the AP projection. Then he passed down the nail, interlocked it proximally and distally, and get the fractures perfectly aligned and stabilized well. Once you run into problems and you have a malalignment after nailing, you have to consider taking out the nail and optimizing your result by the use of blocking screws. Once you have your valgus deformity, you have to correct it, and you have to get this proximal part of the fracture to the lateral side. So you take out your nail, you block the original canal of the nail, and then you reinsert it, and the proximal fragment will be better orientated. So you always place your screws on the concave side of the deformity. This works as well in the procovatum deformity. Then you have to put the screw behind the nail to prevent bending of the proximal fragment. Here you see a clinical situation with the polar screw lateral to the proximal part of the nail, just aligning the proximal fragment in relation to the nail. A specific case that has nothing to do with your primary operation is the secondary malalignment, a loss of reduction. If you have undisplaced fractures and you fix them with classic devices, you have parallel screws with a high amount of mobility between the locking screws and the nail, then you can get a secondary dislocation of or displacement of the proximal fracture because high bending forces are acting on this proximal fragment like the patellar ligament. This can be avoided by multiplanar proximal interlocking. This is the literature dealing with malalignment, the optimal starting point in the use of the femoral destructor. In case of malalignment, you can use blocking screws. You should use multiplanar proximal interlocking, and this works as well with external intraoperative fixation. It's slightly different for distal fractures. Malalignment often is valgus malalignment, especially if you have an intact fibula or you have already fixed the fibula, then you can get a slight valgus malalignment and you can get a slight flexion of the distal fragment in an antecovatum deformity. Once again, it's very crucial to point out that the nail may never reduce these malalignments. You have to reduce this before nailing. The optimal entry portal is important, but not as important as in the proximal fractures. You have the same technical tips and the same reduction tools. I will emphasize on percutaneous clamps, on the fixation of the fibula as reduction aid, and of guide wiring the fracture and probably reaming and slide hammering during nailing. If you have a very distal lower leg shaft fracture, you can reduce the fibula. This should always be done first to get a preliminary alignment. Then you can nail it and fix the distal fragment. Then you should go for nails that offer at least 3 interlocking options in your distal segment. If you have extra-articular fractures, you don't need to fix the fibula. You go down with a nail if ever you want to operate such a fracture, and you can interlock it with 3 or 4 distal interlocking screws. Once you want to nail simple articular fractures, the most important is that you have to address your joint fracture before nailing. So you have to get an open or closed reduction and stable fixation by leg screws, and then you can nail the metadiaphyseal fracture of the tibia. This is working as well in comminuted distal shaft fractures in combination with simple articular fracture. So you treat 2 fractures, one with leg screws in the ankle joint and one with a nail, and you get good healing in general. If you treat complex articular fractures, which I would not advise to everybody, you have to proceed differently. And this is why I want to show this case. It's not a case that should be normally nailed, but this case shows very good how you can treat it with a nail and what are the steps to get an acceptable result. We have a pilon-like fracture extending far proximal in the tibia. First external fixation until soft tissue healing, and then he got in the OR a second time, and the joint block was reconstructed by leg screws. Then the proximal fracture was secured by percutaneous clamps, and a wire for nail insertion was brought in the tibia and just centered perfectly before the nail was taken into the hands. Then a slight reaming was performed just to reduce forces of the nail in the distal segment, and the nail was slipped in over the guide wire and then interlocked with multiple interlocking directions. If ever you treat these distal, tibial or lower leg fractures, consider fibular fixation. You see a distal lower leg fracture, the fibula is fixed and anatomical reduction is obtained. In this rather similar case, you have a slight valgus malalignment, still acceptable and fixed stable by the 4 interlocking options of this nail. Once you have a malalignment, primary or secondary, and a nail that is not sufficient for stability, you will run into further problems in the further course of the treatment. So in these cases, consider fibular fixation as primary reduction aid or as secondary stabilizer of your osteosynthesis. The literature is dealing with malalignment rates and with secondary malalignment rates that may decrease with fibular fixation. Delayed weight bearing is always recommended. In general, it can be accepted that it works in selected fractures. So, as a summary, nailing in proximal and tibial fractures may be a good option. Attention to detail is key to success. If you want to get a good reduction and a good stable fixation, you have to first obtain reduction and keep it throughout your operation, and you have to go for the optimal entry portal. Simple articular fractures may not be a contraindication for this procedure, and you must use all the tools that you have for reduction, for obtaining reduction and keeping reduction. Keep in mind, the straighter the street, the easier you walk on it, but always be aware and be prepared to surprises. Then you have a plan B and you can save your operation. Thank you very much.